I'll tell you up front, I'm not a public speaker, but I'll speak to you about one of my greatest passions, and that is hospice. Hospice is palliative care, and talking about palliative care, a lot of people will say, well, what is that? And that is where we focus on comfort care, because through the medical process, the patient has been told that they're terminal, that they have 6 months or less to live. In looking at terminal diagnosis, a lot of us think, well, it's cancer, but it's more than that. Many diseases will end up being in a terminal state, whether that's kidney failure, that's heart failure, liver failure, Alzheimer's disease, dementia. It all reaches a point that with medicine we cannot truly manage the disease process to make it better. So we look at quality of life versus quantity of life with hospice, with the patients. And so I thought I would tell you the process of how we put the hospice plan of care together for the patients. First of all, we will get a call from a family member, or we'll get a call from a physician stating, I'd like you to talk to this patient and their family about hospice care. I want you to tell them what it's about and answer any questions. So we'll contact the patient, the family members, whoever needs to be involved in that talk at that time, and we sit down with them and we find out what they want. Because it's not always about what we want as a family member, it's what that patient wants also. Sometimes that patient's afraid if they say, I do not want to try any more curative care, I do not want to do any more chemo, I do not want to take this medicine anymore, I'm having to get up 15 times a day and go to the bathroom, to get rid of the extra fluid. I just want to be kept comfortable, and I want to make the days that I have left the best that they can be. But they're afraid to say that because they're afraid the family will interpret that as giving up. And that's where we need to look at what the patient wants, but also the family members to be able to comfortably say, I've seen what you've been going through, and it's okay if you don't want to do that anymore. With this team, we can make our days the best that they can be. And so when we get together and we talk with the families, we design the plan of care at that point in time. We decide which doctor is going to be involved in the care. We have a medical director that is always there for the patients, and an assistant medical director if their family member, chooses to utilize or the patient to utilize our medical director if the physician is out of town. We have that backup person there. And then we talk about frequency of nursing visits, where that patient is at with their disease process. Do they need a nurse every day? Do they need a nurse a couple of times a week? We talk about that, and then we talk about the medications that they're on, what they want to continue, what they don't want to continue, or maybe we need to look at pain management, because there's so many other sources other than just taking a pill for pain management. Topical patches, we have topical, our patients refer to them as lotions, but it's a cream that can be put on the wrist, it can be put on the ankles and things like that for absorption. So if they're having difficulty swallowing, we have alternatives versus having to give injectables or IV medications and things like that. So we look at all of that, and then we report that back to the doctor. This is what the family and the patient would like to do with their plan of care. And then we decide about an assistant in the home, if they're in the home setting, it being their residence versus a nursing facility or a family member's home. Do they need help with some housekeeping? Do they need somebody to do some errands? Do they need some meal preparation? Do they need somebody to come sit for 4 or 5 hours a day so that primary caregiver in the home can go get their hair fixed, or go down and have a cup of coffee at Holders, or run out to Walmart and get some groceries? Maybe they just need to go take a nap or take a bubble bath or something like that, but knowing somebody's there with that patient if they need anything. So we put all of that into play and what they think they need, and we try to develop the time frame that works best for the patients or the families. Now if they're in the nursing home, we can still send somebody in there to sit with them, hold their hand, things like that. And Dick Miller is one of those great volunteers. We have our volunteer program. We're always looking for more volunteers. But do they need somebody to do that with them at the nursing home? And I think Mr. Miller can tell you it's a very rewarding experience, because they have so much to share with you. And maybe they tell you things they don't feel comfortable in telling the family member, their minister, even us as nurses. But that volunteer that we put in there, they develop a very, very, very close relationship with. And so we talk about the volunteer program, and then we talk about spiritually where they're at. Every patient gets a spiritual evaluation Right now that's done by Pastor Bershey with the Lutheran Church. He'll be leaving us in May, going to Moore, Oklahoma. So we're always looking for ministers to step into that role. But it's not the time for us to try to redesign their faith or to convert their religion to something else, So we embrace that. And then if they have their own minister, we involve them in the care. If they do not have a minister, if they want a minister to visit them, we arrange for that. And what is great is that we have some of our volunteers that are very good at sharing the spiritual experiences and things like that with our patients, and so they're involved at that level. And so, again, we look at that, we look at the nursing visit, and then we have sometimes volunteers that will come in and visit, and sometimes our patients just love to hear about the basketball game on Friday night or what's going on, at the college or the university. We have volunteers that will send cards at holidays and things to our patients. So we try to enhance their life and keep them involved in community activities and what's going on. And once we get everything together, then we meet every 2 weeks as our hospice team to see if our plan of care is working for that patient. Our medical director's there, the nurses there, the volunteer coordinators there, our ministers there, and we see what we can do better as an agency to meet their needs. And that's really important. We have feedback from family members with that. We have feedback from the nursing home and their workers, what they think that we need to do to make things better for the patient. But we feel that it is such an honor to be able to spend this end of life with our patients. We're a guest in that process that is so private in their lives. They share sometimes fears with us that, we help them work through. Sometimes they just need somebody there just to re-inventory their life and to talk about what they've done or what they wish they would have done, and need that encouragement that, your life was good and you made a difference in what you did. But dignity is the main thing that we look at in hospice, that every patient has a right to die with dignity and with respect and with the care that they choose to have, and to let them know that it's okay if they do not want to take this medication anymore. We explain the processes that they're going to see, and we explain it to the families of what it's going to look like in the end of life care. That, we're going to change in our appearance, we're going to quit eating, we're going to quit drinking, and that's okay. We're not starving that patient, we're not letting them lay there and thirst. That is part of the process, and so we really try to educate and let everybody embrace that, so they're not afraid of that they can honestly sit there and tell the patient that it's okay to let go, that it's okay, that they're tired of fighting that battle, whether it be cancer or another disease process. But hospice isn't for everyone, and I will say that. You have to be willing to embrace that part of end of life and not be afraid of the end of life process. You learn so much through the patient that is going through this process, and, they are just... I don't know how to put it other than they're just ready, and they're so okay, with what's gone on in their life, and they understand that process, and they're not afraid to say that, this is the best it's going to get for me. I've lived a good life, and I want to be kept comfortable. And by being kept comfortable, that is not making somebody where they cannot respond to visitors or anything like that. What we try to explain is as their pain level increases, then their pain medicine is going to increase, but we do not try to make it where they can't communicate. There will be a point that they're going to be kept comfortable and they're going to be resting, but we try to keep them as comfortable and interactive as can be. We look at signs of pain other than them verbalizing it by grimacing, posturing, the tenseness of the muscles and things like that, because we get that question. If their eyes are closed and they appear okay and they can't communicate, how do you know if they're hurting? We look at the whole total aspect of their body from head to toe. When our aides go in to give a bath to the patient, they do the head-to-toe assessment of their skin. They take such time with them so that they're not rushed through that bath process, because being kept clean is part of, having that dignity. If you have visitors and things like that, you want to be comfortable. You want to know that, you're clean and things like that. So we look at that. It's just that basic respecting life and where that patient is at in their process and where they want to be. I know Mr. Miller can tell, many stories. He's touched so many lives and has been there in that end-of-life process. And through people like him, our program is enhanced in being able to reach out to others. But hospice, it's dear to our hearts. It's, what we love to do. And through the process, we have learned to accept a lot. We've learned a lot from our patient. There's not a patient that we haven't learned something from. We've had all aspects of different religions. If it's a religion that is not necessarily being practiced here in Alva, Oklahoma, or the surrounding areas that we service, we have to find somebody to come in, whatever religion they are, if they need that, to work with them on their spiritual side, which we do. We have contacted people, in Oklahoma City and Tulsa and things like that. And it may not be necessarily our belief, but it's their belief, and we embrace it. And you'll learn so much from embracing where they're at, and understand their process of going through the end of life. But we've been here for a lot of years. Barbara Loudon started our home health agency and our hospice program. We owe it to her where we're at and how we've grown. And we're compassionate again about what we do. If you all have any questions about our hospice program, we do offer other programs within our home health agency. Please feel free to contact us because we want to answer the questions. There's so much to hospice. I could go on forever about it and the wonderful experiences we've had and the honors that we've had in being involved in this part of a person's life.
One of the first time I was assigned a couple of patients. Was one woman and she was afraid of me. I would just go up to her and she was afraid, and there's no point in trying to impose myself on her, and so that was just a wash. But the good times have been with patients who appreciate being read to. So I'll get everybody's favorite poems. I'll read those or read a story. There was heard a book recommended, the Code of the Woosters, and so I read that to a woman who was dying, and we had a great time with her. In fact, she went into she started being pretty far down on energy and such. So instead of going once a week, I went every day because I wanted to see the end of the story. And so we had that. One of the really fun things was an assignment to when I was with Lori Johnson. I'd go into the lunchroom at just about at lunchtime, and there was a woman there who was in a wheelchair but always had a loud voice, and I said, "Oh, it's yourself, is it?" And we'd banter back and forth and have a good time. And then a week or two later, I was assigned to her, and so we just hit it off fine.
One thing that Mr. Miller pointed out that is so important is that time that hospice has with that patient. It's not about, us coming on service 2 weeks before they pass, which happens a lot. It's if they accept it early on and the volunteers can work for them and get through the anger process, and our ministers can work with them on the spirituality, that's when they get the whole package, and they get just the interaction, the relief, and going through the stages of grief. And so never be afraid to call us up and say, well, what do you think? And we review blood work. We review all the stuff with the doctor to see if they're in that time frame that we can benefit them. I want to leave you with a couple of quotes, and this one is from Stephen Levine, and he said, "You are with the one who is dying in the same way you are with yourself. Open, honest, and caring. If it hurt, it hurts. If it makes you happy, it makes you happy. Just hear the truth that the moment has to offer." And that's what we believe, is to be honest with our patients about where they are in their process. And then the last one I'll leave you with is, if a man wishes to be sure of the road he treads on, he must close his eyes and walk in the dark. Thank you for having us.